Okay, from here we'll move into neurological testing. The neurological examination of the cervical spine needs to be done with some care. In the post-traumatic patient, particularly in the early stages, great care has got to be taken to look for central nervous system signs. And this would include the cranial nerve screening test as well as the spinal cord reflexes and so forth. We're not going to cover that on this particular tape. That's actually covered in volume 6. We'll be covering the routine tests that are carried out on the non-traumatic or the older traumatic patients. And again, these will consist of dermatome, myotome and reflex testing, as well as spinal cord reflexes, which again are necessary in this region because of the presence of the spinal cord and the possibility of disc herniations onto it. Okay, with the dermatomal tests, we can again use light touch or pinprick. And again, if possible, when you're using pinprick, if you can test both sides simultaneously, it'll be more effective. But let's start with the light touch and pinprick. Okay, you really start off at C3. Most of this area, C4 rather, most of the C2-3 area is trigeminal in the face, and the upper rami for the back of the head is very difficult to test. So you start off usually with C4, and C4 essentially runs through this region. And if you're doing light touch, of course, it really doesn't matter. Tell me when you feel this. Yes. Yes. And you just cover as much of the limb as you can, yes, having them say yes as you go. Yes. And for pinprick, C4 against C4, feel the same? Yes. Okay, C5 against C5, yes, C6 down through here against C6, yes, 7 against 7, yes, 8 against 8, yes, 1 against 1, yes, and 2 against 2. One of the interesting things with dermatomes is actually probably a different dermatomal map for every textbook you read. And I think what you have to do is take the one that seems to be the most consistent between them all and use that one. Okay, we can then move on to myotomal testing. C1 we can test with short neck flexion. Just the finger underneath the chin, don't let me lift your head up, and relax. C2, 3 are really the accessory nerve, so we won't test those again. For C4, the best way to test this is to use levator scap. Again, if you simply use shoulder elevation, trapezius is going to kick in, and that's accessory. So for the levator scap, just spin around for me. We can come into this position. Just put the heel of your hand over the superior angle of the scapula. Let the patient shrug their shoulder up just slightly to give them an idea of where they're going. And you just say, don't let me push your shoulder down. And you push through that inferior angle. Now, if this is weak, you'll feel the scapula just come down and abduct as you do this. And you're looking for a nice, strong resistance to your test. For the other side, just come onto it there. Don't let me move you. And relax. Spin that way for me again. For C5, we've basically got two muscle groups rather. The abductors, don't let me move you, and the lateral rotators, don't let me move you again. And if you notice, I'm testing bilaterally. If you can do this, you'll pick up problems much more sensitively. And if you watch Beverly here, you'll see what I mean. Don't let me move you. And you can see that left hand just giving way. Now, this is non-fatigable, so I don't expect this to be an active neurological lesion. For C6, we can use the elbow flexors. Don't let me move you. And push down, and we're getting some weakness on that left side again. And the alternative muscle for this will be wrist extension. So don't let me move you. Now, when they do this, don't let them straighten their fingers out because they'll be bringing in C7. So they keep their fingers flexed, push up underneath the wrist, push down on the hand, and this is a fairly easy one to break in most people. There. and compare with the other side. Don't let me move you. Good. For C7, triceps. This I find probably the best way of breaking this one is from the back. Don't let me move you, and you can sort of lever them against your chest and just carry out the test like so. And the alternative muscle is wrist flexion. Again, don't let them grip, otherwise they're hitting C8. Don't let me move your wrist. Good. And don't let me move your wrist. Lovely. Okay, C8, thumb extension. Don't let me pull your thumbs down. And the alternative finger flexion. Grip for me. Don't let me move you. And relax. Don't let me move you. And relax. T1, the intrinsic muscles of the hand. Can you put your hand out? So you can do a screening test this way. Keep your finger straight and squeeze and pull out. Now if you find one side is coming out easily, then you can come in and test the abductors or the adductors specifically. Okay? And as I said to you before, if you find an intrinsic weakness and they've got a cervical problem and this is related, this is often something very serious. Quite frequently it's a tumour on the apex of the lung on that side. Sometimes the patient's too big for you, then you've got alternative methods of testing, particularly triceps. To do this one, you can bring the arm up, lengthen the triceps out fully, don't let me move you, and test it in this position. Now, it doesn't matter whether you test in the lengthened or the shortened position because you're comparing sides, but make sure you test the other side in exactly the same way. Okay? Okay, now, from the myotomal test, we can move on to reflex testing. And again, we don't need to be confined to the usual ones. And we can start off at C4. Again, usually it's C1, they're not that keen on you doing that, so start down here. Can we swing you around? Okay. Thanks. And we're going to hit the muscle in its belly, so it's running from there to the neck. So we're just hitting there and look for the scapular movement there. Okay. C5, 6, you can actually use rhomboids as well as the traditional ones come in there, like so, and there's an alternative muscle for C5, 6. For deltoid, we can hit right on the, try to hit near the 10 of the deltoid, quite high up there, and very frequently you'll actually see the arm abduct like so. Otherwise, you're looking for the muscle contraction in the belly of the muscle. C6, biceps. Thumb across the biceps tendon there, and just strike your thumb and feel for the contraction underneath your thumb, and also look for the movement in the muscle. For triceps, two ways of doing it. The easy one for me anyway is to bring their arm into this position and just hit the triceps tendon there. But the other way that a lot of people find easy is put your hands on your hips for me, have them put their hands in that position, and then you can come down and hit like so. And people find that one quite easy. Can we spin you around again? So that's C7. C8, we can use the extensor pollicis, or the abductor pollicis actually, either one. And what you do is you come in about a third of the way up the forearm and aim towards the radius and look for the thumb to extend as you hit that tendon. And there you can see it happening there. C1, you can use the thenar muscles, but the opponents, I believe it is C8. You're better off coming onto the hypothenar, relax for me, pull the wrist across so that you radially deviate and adduct that little finger, and just strike into the belly and look for the muscle to contract in the belly. There. The long cord reflexes, again, knee jerk and ankle. Is this a bad one?
No, it's good.
There. And you can test clonus in this position as well. And of course, the extensor plantar response. One of the nice things about the neck is that all of these tests can be done in sitting. You don't need to keep shifting the patient about.